Hi there, welcome to our channel where we make medicine easy to understand. Today we are talking about papilledema, a crucial topic for medical students and future doctors. You will learn what it is, why it happens, how it presents, and how to manage it. Let's get started. Papilledema refers to the swelling of the optic disc caused by increased intracranial pressure, that is ICP. Majority of cases of papilledema are bilateral. However, unilateral papilledema can be seen in Foster-Kennedy syndrome and pseudo-Foster-Kennedy syndrome. In Foster-Kennedy syndrome, optic atrophy is visualized on the side of lesion, and papilledema is seen on the other side of the lesion. And the reverse is true for pseudo Foster-Kennedy syndrome. So let's first go through the CSF circulation. CSF, that is cerebrospinal fluid, is formed in the choroid plexus. From there, it reaches the cavity of lateral ventricles, and from there, it reaches the cavity of third ventricle via foramen of Monro. From third ventricle, it reaches fourth ventricle via aqueduct of Sylvius, and from the cavity of fourth ventricle, the cerebrospinal fluid reaches subarachnoid space through foramen of Magendie, that is located medially, and foramen of Lusca, that is located laterally. And the absorption of cerebrospinal fluid occurs via arachnoid villi into the cerebral venous sinuses. So let's know about the causes of papilledema. Congenitally, it might be due to aqueduct of Sylvius stenosis and craniosynostosis. Intracranial space-occupying lesions like abscess, tumor, tuberculoma, and gamma can also lead to papilledema. Infectious pathology includes meningitis and encephalitis. Similarly, hemorrhages like subarachnoid hemorrhage and intracranial hemorrhage can also lead to papilledema. Spinal cord tumors can also sometimes lead to papilledema. Similarly, it can be seen with idiopathic intracranial hypertension, cerebral venous sinus thrombosis, and finally, in systemic conditions like hypertension and dyscrasias. Now let's discuss the pathogenesis of papilledema. So Ayres theory is the most acceptable theory for papilledema. It states that papilledema develops as a result of stasis of exoplasm in the prelaminar region of optic disc due to alteration in pressure gradient across lamina cribrosa. So optic nerve is surrounded by subarachnoid space, which contains cerebrospinal fluid, and whenever the intracranial pressure is raised, it leads to compression of optic nerve, which leads to interrupted exoplasmic flow in optic nerve. And then it results in stasis and accumulation of exoplasm in optic nerve head, which causes axonal swelling, which leads to venous congestion, and finally extracellular edema, that is papilledema, develops. Now let's discuss the symptoms of papilledema. Since papilledema occurs due to increased intracranial pressure, features like morning headache, nausea, projectile vomiting, and diplopia are seen. Now let's discuss how diplopia occurs. So first, there is increased ICP, that is intracranial pressure, which leads to downward herniation of brainstem. Next, abducens nerve sheath gets compressed at the petrous tip at the apex of petrotemporal bone, and since abducens nerve supplies lateral rectus muscle and is compressed, there is no abduction of the eye, and the unopposed action of antagonistic medial rectus muscle causes esotropia and finally leads to diplopia. Apart from these, features like transient vision loss, enlarged blind spot, and pulsatile tinnitus are also seen. So transient vision loss occurs due to raised ICP, which causes swelling of optic nerve head, which in turn disrupts the normal blood flow to optic nerve, leading to temporary ischemia and impaired visual function. Enlarged blind spot occurs due to separation of retina from disc and progressive contraction of visual field due to optic nerve atrophy. And finally, pulsatile tinnitus is seen due to increased ICP, which causes turbulence in the blood flow within venous systems near the brain, which finally causes audible whooshing sound that synchronize with the heartbeat. Clinical features of papilledema can be described into four stages. They are early or incipient papilledema, established or fully developed papilledema, chronic or long-standing or vintage papilledema, and finally atrophic papilledema, which is also known as post-neuritic optic atrophy. So in early papilledema, there are no symptoms, visual acuity is normal, and pupillary reaction is also normal. Ophthalmoscopic features include obscuration of disc margin, nasal first, followed by superior, inferior, and temporal. And then there is blurring of peripapillary nerve fiber layer, absence of spontaneous venous pulsation at the disc, mild hyperemia of the disc, splinter hemorrhages may be present in peripapillary region, and visual field is fairly normal. In established papilledema, symptoms like transient loss of vision can be seen, visual acuity is usually normal, pupillary reaction is normal, and ophthalmoscopic features include apparent disc edema, obliteration of the cup, multiple cotton wool spots and superficial hemorrhages, and veins become tortuous and engorged. Patterns line, which are circumferential gray-white folds, may develop due to separation of nerve fiber by the edema. Hard exudates may radiate from fovea in the form of incomplete star, and also known as macular star or macular fan. And visual field shows enlargement of blind spot. Talking about chronic or long-standing or vintage papilledema, visual acuity is reduced. Pupillary reaction is usually normal. Ophthalmoscopic features include cotton wool spots resolve, peripapillary edema is resolved, optic disc appears like dome of champagne cork. We also can see corpora amylaceae, which are nothing but small drusen-like deposits, and the visual field shows enlargement of blind spot, and visual field begins to constrict. And finally, talking about atrophic papilledema, which is also known by the name of postneuritic optic atrophy. So this stage develops after 6 to 9 months of chronic papilledema and characterized by severely reduced visual acuity. So in this stage, pupillary reaction shows impairment of light reflex, and ophthalmoscopic features include grayish-white discoloration and pallor of disc due to atrophy of neurons and associated glasses, decrease in disc prominence, retinal arterioles narrowed and veins become less congested, and white seething around vessels can be appreciated. So visual field shows concentric contraction of the peripheral fields. Now let's go through the Frisian staging of papilledema, which is solely based on fundoscopy. So in grade 1, grayish-shaped halo surrounding the disc can be seen, sparing of the temporal disc margin, and radial nerve fiber striation disruption can be appreciated. In grade 2, halo becomes circumferential, nasal border elevation is appreciated, and no major vessel obscuration is seen. In grade 3, obscuration of at least one vessel leaving the disc is seen, elevation of all borders, and circumferential halo. Grade 4 shows features like obscuration of major vessel on the disc, complete elevation including the cup and circumferential halo. In grade 5, features like obscuration of all vessels on the disc and leaving the disc, plus all features of grade 4 can also be seen. Now let's discuss the investigations of papilledema. There are three modalities for investigation in case of papilledema, which include ophthalmic investigations, neuroimaging, and lumbar puncture. Ophthalmic investigations include optical coherence tomography, fundoscopy, automated perimetry, fluorescent angiography, and B-scan USG. Neuroimaging modalities include CT scan, CT venogram, MRI, and MRV. Talking about optical coherence tomography, it measures retinal nerve fiber layer, and along with ongoing papilledema, the thickness of retinal nerve fiber layer increases, and with resolving papilledema, retinal nerve fiber layer thickness decreases. However, sometimes optic atrophy is seen, for which macular scan is done. Next, fundoscopy is done for documentation of papilledema, and automated perimetry can detect enlarged blind spot. Fluorescent angiography distinguishes true and pseudopapilledema. In true papilledema, there is leakage of dye, while in pseudopapilledema, no leakage of dye due to drusen. We can also perform beta scan USG, which visualizes and measures optic nerve swelling, especially widening of the optic nerve sheath. Let's discuss the neuroimaging modalities. CT scan is done to rule out intracranial space occupying lesions. CT venogram is done to rule out cerebral venous sinus thrombosis, and MRI and MRV are done to rule out meningitis. In lumbar puncture, we look for CSF composition and CSF pressure. Note that we have to rule out intracranial space occupying lesions and tonsillar ectopia before performing lumbar puncture. Now, let's move on to the treatment modalities of the papilledema. First, we have to treat the underlying cause. For hypertension, we have to control blood pressure first. For intracranial mass, surgery, radiotherapy, and chemotherapy can be chosen. For cerebral venous sinus thrombosis, anticoagulation therapy is to be started. For idiopathic intracranial hypertension, the most important step is weight reduction, and we also have to stop vitamin A and tetracycline analogs. To save vision, decompressive surgery is done, which includes optic nerve fenestration surgery and dural venous shunting in the form of ventriculoperitoneal shunt and lumboperitoneal shunt. In optic nerve fenestration surgery, holes are created in optic nerve sheath, while in dural venous shunting, it simply creates diversion for the flow of CSF, and both optic nerve fenestration surgery and shunting surgeries decrease pressure around the optic nerve, helping to save vision. Note that decompressive surgery should be performed before visual field constriction becomes significant. Finally, let's talk about some differential diagnosis of papilledema. First, we have to differentiate the optic neuritis from papilledema. In optic neuritis, there is unilateral sudden onset, sudden loss of vision, while in papilledema, it is mostly bilateral, it is insidious onset, and there is gradual loss of vision. In optic neuritis, moderate disc swelling is seen, while in papilledema, marked disc swelling is seen. In optic neuritis, central field defect is seen, while in papilledema, concentric contraction of visual field is seen. In optic neuritis, RAPD is positive, while in papilledema, RAPD is negative. The second differential diagnosis we have to talk about is AION, that is anterior ischemic optic neuropathy, for which the most common age group is more than 40 years of age. There is sudden loss of vision, there is decreased color vision, central field defect and altitudinal field defect are seen. RAPD is positive. Lab shows raised ESR, CRP, for which there is high specificity. Also, temporal artery biopsy can be done. And finally, let's talk about idiopathic intracranial hypertension, for which the risk factors include obesity, anemia, systemic lupus erythematosus, synthetic growth hormone analogs, tetracycline, and vitamin A derivatives. And for idiopathic intracranial hypertension, we use a criteria called Dandy's criteria, which includes signs and symptoms of increased intracranial pressure, documented high intracranial pressure in lateral decubitus position, normal CSF composition, no hydrocephalus, mass, structure or vascular lesion on MRI or CECT for typical patients, and MRI or MRV for all others, and finally, no other cause of intracranial hypertension identified. To recap, papilledema is a bilateral swelling of the optic disc due to raised intracranial pressure. It has many causes like brain tumors, hydrocephalus, or idiopathic intracranial hypertension. A detailed history, fundoscopy, and imaging are key to diagnosis. Treating the underlying cause is critical to prevent vision loss or worse outcomes. Thanks for tuning in. If you found this video helpful, don't forget to like, share, and subscribe for more bite sized medical lessons. See you in the next video.